Thanks everyone for joining us tonight. My name is Melissa Linsman. I'm actually the Primary Care Transformation Lead with the London Middlesex Primary Care Alliance. There we go. So for the agenda for tonight, just go over a couple housekeeping things with you and kind of some technical details. We'll do a very short kind of welcome and introductions from our co-chairs of the LMPCA. Then we actually have two agenda topics for tonight. The first one being Children's Mental Health Services. So that'll be Scott Colby from Vanier will be presenting there. And then we'll have a topic on advanced access, and that'll be Dr. Vineet Nair. At the end of our town hall session today, we'll be going over a couple of leadership opportunities for primary care, and just we'll also have some time for question and answers and anything we want to talk about. Right. So just for a couple of housekeeping things, just a reminder to stay on mute if you're not speaking. And then if you do have a question, you're welcome to use the raise hand feature in Zoom, or you can always type it into the chat. We'll be monitoring the chat to try and facilitate some of the discussion and the questions and answers. We will be sending out main pro certificates to the attendees, but we ask that you rename yourself for your actual name if it's not like that already, just so we know who you are and we can send them correctly. Just another plug here, if you haven't already signed up for our LMPCA newsletters, you can do that. We'll be sending the link in the chat in the future. And then another reminder here that this meeting is recorded. We'll go out to our full mailing list and with the slides early next week. All right. So I'll hand it over to Scott Cordis and Vineet.
Thank you so much, Melissa. I'm Scott Cordis. I'm the Executive Director of the London Intercommunity Health Centre and one of the co-chairs of the London Middlesex Primary Care Alliance, joined by other co-chair, Dr. Vineet Nair. So before we get into the main program, just wanted to give a little bit of background about the London Middlesex Primary Care Alliance in case this is your first engagement with us, and so we do a little bit of a show so you know who we are. So we are an inclusive network of primary care providers that are leading with a unified voice to improve the health of our community. So we've come together to create a strong and united primary care network, really to help lead systems change, utilizing quadruple aim values, drive health equity and continuous quality improvement for the best possible experiences and health outcomes for the folks that we serve, advance patient-centered equitable care in partnership with those that we serve, and also improve the integration of primary health services with public health and other social service and healthcare partners. So we'll talk a little bit later about how, if you're interested in engaging and joining and being active in leadership in the group, but we're just really pleased that you've joined us tonight, and thank you for your attendance. And you'll hear a lot more from co-chair Dr. Nair, who has a whole speaking part at the end of this. So thanks for joining us this evening.
Thanks everyone for joining us. I guess I will be the one to hand over to our speaker. Scott Colby is a clinical director at Vanier, and he's here to educate us about the services they can provide and how we can best access them. So Scott, I'll hand it over to you.
We can't hear you, Scott. No.
Nope. We heard him moments ago, so we know he's around.
Can you hear me now?
Yes.
There you go. Yep.
Okay, so if some crazy silence comes over the screen, just somebody like wave at me or yell something, and it appears I have to unplug and plug back in. My system seems to like me more than it likes Zoom. I don't know what to tell you. So I'm going to just quickly jump in. Thanks. I really appreciate being here tonight. And in some ways, I feel like this is a little bit like the Holy Grail. Like children's mental health has been trying to get connected to tertiary care and the hospital and primary care for a long time. So I'm really, really excited to be here to speak with you. So hopefully I can get this working. Okay, can you see that? I hope.
Yep, we can see it.
All right, so I'm from Vanier Children's Mental Wellness. So we are the lead agency for London Middlesex, and I'll explain maybe a little bit later what that is. But I'm just going to really jump into some like 10,000-foot view stuff, and what I really hope to be able to do towards the end of my presentation is help everybody understand how we might easily help create pathways for patients in your care to get mental health supports and services, like the right support at the right place in the right time. So I'll get to that, but just sort of some key statistics. I'm probably sharing stuff that you already know. We know that 1 in 3 parents in Ontario are seeking mental health support for children. And 4 in 10 say that they are, even if they found it, they're still waiting. We know wait lists are crazy right now. 2019 numbers suggest that the economy loses, $421 million each year to parents. And the COVID-19 pandemic is really, I don't even think we know in the end what it's meaning. I can tell you that the level of acuity we're seeing both in adolescents and really little people is startling and very concerning. So these are just some kind of statistics from the area. I won't go through them all, but I think you can just see by the numbers how everything is increasing, like not in a good way. Increases in self-harm, increases in suicide attempts, increases in wait lists. So quite alarming, quite challenging for the system, especially a system that hasn't had any new money in a lot of years, and we're just trying to make do with the best that we can. So the overview of Vanier's programs and services. So we have a variety of services. So we have intensive services. You can see on the list there, we have live-in treatment beds. We have an eating disorders program. We have an on-site treatment classroom. We have a EIP program, which is like an early intervention program for JK and SK students. We have intensive family supports, which is sort of parent support when there is parent-child conflict in the home. And then we also have a day respite program. So those are intensive services. And then in community, we have a whole host from different therapeutic modalities, a brief model, a more sort of long-term model, walk-in, talk-in clinics. We also have care and pair clinics, which I will dive into a little bit because I think that might be of interest to folks, particularly county folks. And then we have a SKIP program connected to school. And we have a telemental health service as well. And then what I think probably will be really interesting to most folks will be the tandem service, because I think that's sort of like almost a one-stop shop that will be really helpful and easy for you to either refer patients to or for you to yourself help connect patients to. So just briefly around our intensive services on our campus on Trafalgar in London, we have Hand in Hand, which is a community funded beds. We have 9, we're licensed for 9 beds in that program. Haven is our eating disorders program funded by Ontario Health. And while it's licensed for 9, we actually run it much less than that to maintain quality of service delivery right now. It's brand new, so we're just sort of getting rolling with it. And our Cornerstone program is directly connected to CAS. So not just London Middlesex, but from all over. The kids in that program right now, there's 6 kids in that program from like 4 different CASs around Ontario. And then we have an on-site WD Sutton classroom. So really low numbers, a child and youth counselor in each class can really build very unique and individualized programs for students in the WD Sutton classrooms. So here are the paraclinics. So the paraclinic is a parent and infant relationship clinic, and this is for children 3 years old or under and their caregivers. and it takes place in family centers in the county. And you can access paraclinics through Tandem, which we'll talk a little bit about later. Then there's the care clinic. So this is for a slightly older age group, 3 to 12, and care stands for child attachment, relationship, and engagement. Works on the same premise around sort of meeting families where they're at, doing single sessions, or providing groups and workshops, whatever is going to be helpful for the parents. You have the HOPE program, which is usually it's run by somebody who has lived experience in children's mental health. So a caregiver or a parent who maybe has a child or a niece or a nephew or some relation with mental health and has lived experience, that then operates this program and provides telephone support. As you can see on the list, there are one-to-one support meetings. They'll do some crisis support and various things. It really such a super cool program, and the person that runs it is absolutely amazing. Our SKIP program is it stands for School Community Intervention Partnership. So this is a partnership with 4 local school boards, and we can receive referrals from the school boards and provide a number of services to school boards as listed, from consultation, intake, and assessments to additional services. We can act as case management and service coordination in some cases, depending on what the needs may be and if there's the need to access other community supports that require case management. And then they'll also do some direct work as well with parents and caregivers around skill building. And then our day respite program. So we used to have overnight, but since the pandemic, we've just sort of stuck with day respite, and we run day respite on the weekdays in the summer, kind of like a camp, like 5 days a week. And then during the school year, it's just on Saturdays and Sundays. And so that's for children 7 to 12. We get generally kind of internal referrals for that program. But it is for children with mental health issues that are having some challenges, either at home or in the community. And it's traditional respite in that it provides a break for parents, but we do sort of have some loose therapeutic goals that exist for the kids in that program, and that's run on our campus. And we also have telemental health services. I don't know if folks are familiar with this, but we have partnerships with a number of psychiatrists around Ontario, and actually one is working for us from outside of Ontario, where they create a calendar of opportunities for families and children to access psychiatric support. So such a cool program. And then there's some extra focus around First Nations, Métis, Inuit, and urban Indigenous, as well as Francophone supports. So I guess this brings us to the big part, really, which is Tandem, and why I think Tandem could be really relevant for primary care. So Tandem is a partnership between Vanier, which is serving children ages 0 to 14, and then Craigwood and Humana are both adolescent services serving children 12 to 18. They have some slight variations in the services that they offer. But this partnership has been in existence for about 20 years now. And it kind of just started as a goodwill partnership. But it has grown both in scope and in numbers. I mean, it started out with just a couple of staff, and now I think we have about 11 staff, and we're in a number of different community venues as well. So, I mean, the whole thing about Tandem is we do feel it's just one call, and through that one call, we can generally make whatever needs to happen. So whether that is just to sort of immediately speak and mitigate crisis for a family, and again, this serves everybody. Anybody can call Tandem. A child, a youth, a parent, a caregiver, anybody can call Tandem. So number one is to mitigate crisis. Number two is to potentially help identify or provide resources. Number three would be to maybe identify whether we need to help create community pathways to additional services. So the clients that we typically hear from, I would say definitely is mostly adolescents, but we hear a lot from parents, and we hear from professionals too, that either hear about us or see our name and our phone number somewhere, and they want to know, what it is we do and how we can help. And so all of our staff are well trained to deal with social, emotional, transitional, or behavioral difficulties. We have mostly child and youth counselors that have some additional training on top, when the additional training is assist training around suicide interventions, PAP-C training around fire prevention and little people who are setting fires, identifying risk and figuring out how to support them. So I guess this is just sort of repeating what I was just saying around, we're there to provide immediate phone intervention. We're there to help with crisis. We can also do in-person crisis meetings. So people could call and they could is there just some way I can come down and see you? Well, the answer is yes, absolutely. If you could be here in a half an hour, we can book a room and we can meet with you and we can do a face-to-face crisis intervention. That tends to be
Sorry, Scott, I think we're losing your mic.
Am I back now? Awesome. Quite often when a parent calls because their child is, maybe demonstrating some suicide ideation, that sort of thing, quite often we will say, hey, is there any way for you to make it down, to our campus and we can meet in person? It's much easier under those circumstances to meet with a parent and a child, or with the child, while the parent waits, and see kind of where they're at, and if it makes sense to build a safety plan, or if we need to take interventions further than that. We do virtual crisis appointments. That's something we certainly got quite good at over the pandemic, was switching to the virtual realm. So we do a lot of that. We offer brief therapy interventions, so like up to 3 sessions, with the opportunity to come back for boosters. Safety planning, as I said. Referrals to community partners. So we have some direct pathway opportunities where we have protocols and agreements with providers, and we can make direct referrals to their intake teams. But even above that, even if we don't have protocols and direct pathways, we have relationships and connections to many, many service providers in London Middlesex. The staff team is so impressive in how they stay on top of what's available and what's not available, and programs that close and programs that open, that they can give families, in the moment, really good advice, information around what's out there. Of course, we don't ever tell anybody what they should be looking for or taking advantage of. We just try to do the best we can and I guess create a choice appointment, basically for them, where they get opportunities to hear what's out there and make their own choice. And then a little bit more formal is around resource connections and navigation, where we do have formal protocols. So that is with Craigwood and Humana, with some of the services that they offer. We're also very tightly connected with CMHA, and now we have tandem staff in the pediatric emerge department at LHSC as well. I feel obviously I'm ahead of myself a little bit here. Where can you find us? So you can find us on the other end of the phone, 24/7. Someone will pick up the phone right in our office from pretty early in the morning, about 8 a.m. till 9 p.m. Monday to Friday. After hours, it goes to reach out through CMHA, and they will do immediate crisis mitigation, and then they will forward a callback, and then we'll get in touch with the family the very next day. So also connected to CMHA, Thames Valley, is we are at their Huron Street location every evening from 2 till 10. And so if an entire family, various age groups, walked into the Huron Street location, the Tandem staff would meet with anybody under the age of 16, and the CMHA staff would meet with anybody over the age of 17. So we can do sort of in the moment services to an entire family across the age spectrum. And then as of September of that says 2019, it should say 2022 actually, we put some staff in the pediatric emerge department to try and help with diversion, because their numbers were getting so insane. And I don't know if anybody's had to go to the pediatric emerge recently, but for a physical plant that was built for 80 or 90 people a day, they were doubling that like routinely, like 160, 180 visits a day. So we were looking at diversion opportunities, and we're also part of the MAP research project there, which is also looking at diversion techniques and strategies, and tracking the data to see how the different strategies are working. So there in the pediatric emerge, for patients coming in that are ASQ negative. So for those who aren't familiar, that's just like a pretty quick suicide rating scale. So if they're ASQ negative, they'll page a Tandem staff immediately, and we can connect with that family or young person right in emerge, help de-escalate any crisis that brought them there, and literally provide a choice appointment in the moment, where we can talk about the services that are available in the community, either create referrals or help do warm handoffs. In the event that they would be ASQ positive, there still could be a role, because social work could get involved, help, maybe reestablish, do a HEDS ED, bring the ASQ score down to either like a non-acute score or a negative score, and then we could meet with them again. In the event that we mitigated crisis, but we kind of felt like that was the best we could do for the night, we would schedule an appointment for them like within the next 24 or 48 hours to sort of revisit their options in the community and how to make sure that they got more short, mid, and long-term supports in the community to meet their mental health needs. So if a client were to come to us, if you as primary care providers were to refer a client to us or make a referral on their behalf, what might they expect when they get to Tandem? I guess in a picture, this is it. Tandem deals with crisis, triages the situation, and then figures out how to, if it makes sense and appropriate, get the family to the most appropriate intake. So, whether that would be with us for, little people under 14, or whether that would be, Humana or Craigwood or another provider that we're connected to. And anything along that spectrum. And that could be anything from, brief services to more long-term counseling services. And it could even be to help support referrals through CSCN for much more intensive services, if that kind of made sense based on what was going on. So these are all of our partners, sort of in our catchment area. I hope people can still hear me. I won't worry about listing them all. People can see them there. Some of them might sort of jump out to people like, oh, that's a bit odd, but like, the London Police and the fire departments, we work directly with the fire department around the TAP-C assessments. We do that jointly with them. Sadly, we have a lot of contact with London Police for some of our young people. We have some really great relationships built there. And then, as I said, FHTV, CMHA, the family health teams, and so on. So the supervisor of the program threw this in here. We had talked a little bit when we met with Rachel and Melissa and others around different ways that we might kind of create referral pathways from primary care to Tandem. The easiest is, and I don't know if people will be able to see that, there's our little tearaway pad I'd be happy to do a traveling roadshow and deliver to everybody. You can just, they're literally the size of a Post-it, and you can tear them off, and it's got Tandem's number right on it. If primary care physicians were looking for something a little bit more formal and trackable, we have a referral form. We have one right here that we've created, but we would be happy to work together with folks around creating something that made sense. I know you guys are on Ocean, we are not. So there'd be, I think, some opportunities to discuss how to make things easy for everybody. We do things similar to this already, really, with LHSC. During the hours that we're not there, they have a referral form that they fax to us for us to do immediate follow-up. And we have that in place with CAS as well. So definitely that's something that we could do that's very workable. So I guess, as typically happens when I'm doing something like this, maybe a tad bit nervous, I've talked very quickly and made it through a little bit earlier than I thought. So wide open to questions.
That's great, Scott. That's the speed factor will be my problem to deal with too in my talk, so we'll be done like early potentially. Yeah, I think we've got a couple of questions. Well, one question in the chat there. I'll kind of maybe start it off there too. But I saw the question was, is the form uploaded on Accuro? That's probably more of a Rachel question, maybe. But in terms of that form, even if if you do that referral form, Scott, and you fax it to that number on the form, does then the Tandem contacts the patient, or does the patient still call directly to the one number kind of thing? What's the workflow there?
That's so the way it works right now, and I'm hoping people can hear me okay.
Yep.
The way it works right now with CAS or with LHSC during the hours we're not there is, this is patient information and consent all in one. So like we have pamphlets, we have like Tandem information so that people aren't flying solo. Whoever was going to referral would do so, explain a little bit, to the best of their ability. And the new brochure we have is fantastic because it explains everything quite easily in a nice little package. And then if the patient consented, you would fax this to us and we would contact them directly. And I can't see anything in the chat unless maybe I were to stop sharing. Maybe then I would see stuff in the chat. But if someone could help me out, then that'd be. I see your hand up. You see that?
Yeah. Yeah. So going back to the form. So Vineet, one of the questions we did have for Scott and team was, is there a referral form? Because that's always a question that's asked. And if there is, can it be built in Practice Solutions or Accuro? And is it needed? So I guess I would pose that question to primary care first. Is a referral form wanted or needed? Number one. And then if you want to put that in the chat, yes or no. Two, because of things like Ocean e-referral, those who are on it, it's a trackability piece of getting a loop back to know that your referral has been accepted through Tandem. So we might work with Tandem in the very near future to look at e-referral and that kind of thing. So we're just right now, I would like to know what primary care would want. Is a phone number better to call in, or what's the workflow you're looking for?
Yeah, those are good questions, Rachel. I mean, I think I'll just maybe answer if you want to put it in the chat what they think. But I do kind of like the idea of faxing it, and then at least I know that maybe it's on Tandem is going to follow through to make sure they connect with the patient. Whereas if I give the patient the number, I'm hoping they'll call, but they may not. Maybe. I guess if we give them both things, and the patient calls, do you kind of connect the two so you don't kind of call them back, or someone else calls them back so they get called twice? Would that be an issue if we did both options there, Scott?
No, I don't think it'd be an issue to do both options. I mean, the thing is, as soon as we were to make contact with the family, we would open a file. And so for some reason, if, I don't know, people felt like they'd heard a name before, or they saw like a dual referral come in, we would probably go into our data management system and just check to see if they were already on file. And if they already were, we would, do our best not to duplicate things. I definitely think in terms of like a process map, going down that road, it would definitely be worth having a conversation with a few folks, like maybe just a small working group to figure out what really made the best sense for primary care. And I know like there were some very interesting questions that I know I've thought a little bit about, like even a feedback loop. So like providing the patient consented to us sharing information back to their primary care provider, like how we would create a kind of seamless loop that would work really well and not, not bog things down or become cumbersome. But I certainly would hope with today's technology, we could find solutions for that. So yeah, I mean, I think it kind of depends how we want this to go and the importance of that feedback loop. If it's strictly a matter of ensuring your patient gets in touch with us, then it's sort of no harm, no foul either way. I think giving them a tearaway, a little post-it note tearaway, making a call on their behalf as long as they've given consent, or sending a form, all work equally well. And I can guarantee the follow-up, like nothing would ever get dropped unless it was like a wrong phone number or a wrong email address, in which case we would probably call you back and see where the error was. But any document like a referral form or a fax that makes it to us, we will definitely follow up on within 24 hours.
Yeah, Melissa, I know there's a bunch of little things in the chat. I don't want to duplicate. So do you want to take one and then I'll take one and we'll go from there, or do you want me to start?
Oh, yeah, I can. Scott, there's a question about the eating disorders program and kind of what age it's for, and does it require a physician referral?
So currently the eating disorders program is a collaboration with LHSC, and so there's like centralized assessment there. So it would be, of course, our mandate is up to 14. Now we got special permission from the ministry to go up to 15 in the eating disorder program. So as of right now, anybody, and I think there's this is another one of those areas where I think there's a lot of room for a future conversation, particularly with primary care. I think Pitcher would probably kill me for saying this out loud, but I think it's a bit cumbersome the way it is right now. And I think it could be smoother and work a little bit better for families and young people who are experiencing maybe not eating disorders, but disordered eating. And I know that that's a bit of a semantics thing, but it's definitely a big deal in the sector. Our program is that group of kids that are sick, but not sick enough to be like inpatient or medically unstable, which would be perfect for our program. Our program was initially set up to be a live-in program. However, for various reasons, we pivoted toward the day treatment program. I think we'll still look towards a live-in program at some point down the road. But right now, with a day treatment program, we can be quite nimble and flexible about different cohorts and those subsectors. So kids diagnosed with ARFID, kids diagnosed with anorexia, bulimia, we can serve those more specifically in smaller cohorts through a day treatment model. So as of right now, the pathway into that program is LHSC, is the eating disorders program at LHSC, where there is a team to assess. There's physician oversight. We have a nurse practitioner who works part-time at LHSC and part-time with us that helps create the pipeline, if you will, of referrals, and they do some of that initial matching, is sort of the word I'll use, matching of young people to try and get a good group into a cohort so that we can, because it is pretty condensed and pretty intense. Our intensive treatment model is not very long. It's DBT informed, and so we do a lot of those strategies and those techniques through a psycho-ed model. So that's the best answer to your question. Again, I think it could be improved upon, but it would be accessed through LHSC right now.
Okay, a couple of questions came in around how do people get the brochures, Scott? So I'm wondering, Melissa, if with the registrations with the webinar, we will have your email contact, I'm going to guess. And Melissa, I don't know if you want to reach out to folks afterwards and either mail or make visits or.
Yeah, so I would say if people don't mind seeing my face, or their reception staff don't mind seeing my face walk through the front door, I'd be happy to take a day and drive around with brochures and tearaway pads and a few other things and drop them off to folks. Because honestly, I think it makes it much more accessible for people. And even if, because I think we're doing so much better with stigma, but it still absolutely exists. And so you can give somebody something in their hand to walk away with. I mean, I'm kind of going to be a hypocrite here. The thing that I love about being actually in the hospital is that the process there used to be like they were given information, but the onus was still on the patient being discharged, make a call the next day. It rested with them. The way we're doing it now is we've taken all the burden off their shoulders. We do everything. We say, we'll call you tomorrow at 10 a.m. and set up an appointment. That's perfect. That's the ideal. But in the absence of the ideal, if we could give them something from a tearaway pad, if they can walk away with a brochure, they can put it on a magnet on their fridge and think about it, read about it, give us a call. They can call us anonymously. They don't have to give it their name. We get anonymous calls all the time. They can call us anonymously and just talk about services. So I would be happy to do a traveling roadshow and talk to people some more and give people information.
Thanks, Scott. And we'll make sure that everyone gets connected with Scott. I'm just putting our LMPCA email in the chat as well. So if you're.
And anybody can email me anytime. Anybody can email me anytime.
We have Scott's email address, and we'll make sure everyone gets connected together.
One of the other questions while Melissa's multitasking there. What are some of the wait times? Are there any wait times for various programs, Scott?
There are. So for brief counseling right now, I think we're sitting at around the 6 to 8 week mark. For intensive family services in-home, I think we're sitting about the same, right around the 6 to 8 week mark. For full family therapy, which is like a 12 to 14 session, more intensive model, that one's a little longer. I believe last time I spoke to the clinical manager in that program, it was hovering around 6 or 7 months, which sounds absolutely deplorable, but if you sort of look around, that's actually like half of what some are right now. Not that that's any better, but yeah, so it's 7 months right now. Like in terms of the agencies that we refer to, so Humana, I know they can connect intensive family services really quickly, like I think within about a couple of weeks. Humana that's a little bit more geared towards one-to-one. So best example I could provide might be a family where the parent or caregiver really is kind of checked out or just unavailable for whatever reason. That could just simply be burnout, that could be addictions, it could be a myriad of things where they're just not quite available to participate in a more collective model of therapy. If the young person is sort of that age where it makes some sense for them to engage in just some of their own work and their own coping strategies, that's where we tend to turn towards Humana. Their community programs team is absolutely fantastic and they do that work. I know their wait list was pretty extensive, but I think they've been working on it and it might be down to about the 3-month mark. What other services? No, if you're getting up into the really intensive services like the live-in services, there'd be no wait list currently for hand in hand. There's a couple of beds in that program right now, but that all has to go through CSCN. There's no direct pathway to that. We have to sort of follow the coordinated services network to access the community funded beds. I hope I've answered that question okay.
Thanks, Scott. Another question here is, what is the geographical area or underserved area for tele-mental health services, and is it up to age 12?
Back to the telemental health slide here. So the geography is irrelevant because they're all virtual. And so how that works is the psychiatrists that are partnered with us, they provide time slots in a calendar. And then as we get referrals for consultations, we book clients into those time slots. And they're all done.
Sorry, Scott, you're kind of cutting out there. You might need a reset of your mic.
Good?
Yep, perfect, thanks.
Okay. So if memory serves, it's not on my slide. I was hoping for that to be there. If memory serves, that's across ages. So I don't think it's not 12 and up. I think it's for all children up to 18. I could get back to you and confirm that, but I'm pretty sure. That's one thing I'm not positive on, but I'm pretty sure for all children and adolescents. And geography is not an issue.
Do you want me to take the next one, Melissa? How many sessions does a child get with the telemental health services, Scott? And what is the wait list to access these services?
So that's sort of intended to be like a single consultation. The supervisor that just took this over is like Superman, in my opinion. He's totally reformed everything that's going on here and gotten new psychiatrists to come on. So I would honestly say this might be a presentation unto itself. And if primary care wanted to know more about this, I would put you in contact with Mike Sawatic, who is the supervisor of this program. I just honestly, if I'm being transparent, I don't know enough of the details about the program. My programs keep me hopping, and I'm only sort of peripherally aware of this. I know he stopped by my office the other day and was super stoked because he got 3 more psychiatrists to sign on. So our calendar is getting bigger and we're creating more opportunities for consultations. So I'd be happy to put you in contact with Mike.
I don't see any other questions. Vineet, as a next step, and I'm only because I can see you on the screen as a physician, I hate to put you on the spot, but if we do a referral form, because it seems to be there's interest in the simplest version of a referral form, could we ask you or you to connect us with someone who can kind of just vet the clinical side of things like we would normally do through the digital coalition? And then that way we can then put it through to the Accuro builders, the PS builders, and the Ocean referral builders. And then what we can do is once those are built, we can send an email out to this group to let them know where to go locate it, and they can upload it into their EMR. And then it's available, it'll be available for anybody else beyond this group. Does that make sense as next steps?
Yeah, I think their feedback from the chat was that having more options was better. And I mean the form that you put up there, Scott, looked pretty straightforward and simple. And I think it didn't have too many boxes and stuff. So it looks like it's probably pretty much good to go. So, but yeah, I think we kind of give that the okay and then get it built for the EMRs. That'd be great.
Great. So we'll put that on our to-do list on my end, Melissa. That takes that off your plate. I'll connect with the Partnering for Quality's Digital Coalition group to get that work underway.
Thanks, Rachel. Scott, I don't see any more questions there. Just wanted to loop back to the beginning of the presentation. I just, my oversight I needed to get you to actually state your conflict of interest slide out loud. It was displayed on the screen, but just for our kind of records, I'm gonna try and share it again.
Okay.
I think I just need to get you to read it.
Okay, no problem.
It should be there.
All right, so the Children and Youth Mental Health System is funded by the Ministry of Health. Vanier Children's Mental Wellness serves as the lead agency for London Middlesex service area, and there are no conflicts of interest. And I never even really told everybody what the lead agency was, but that just means you have to invite me back and we can talk some more and I'll tell you what the lead agency does, and maybe I'll bring Mike with me and we can talk about telemental health.
Thanks so much, Scott.
Awesome. And then just let me know names and addresses, and I will I'll bring information out to folks. And thanks so much for having me. I really appreciate everybody. Thank you.
Thanks so much, Scott, for being here. Right. Moving on to our next agenda topic, which is advanced access. I will get that one pulled up. Sorry, just give me 1 second.
Yeah, a bit of a segue here to a different topic. The connection I'm trying to make here is this is probably for the mental health of the physicians here more than anything else, and hopefully it'll kind of give some hope to the scheduling challenges we face. Great, thank you. So yeah, so I'm going to be talking about advanced access, the scheduling philosophy, trying to look at how to balance supply and demand in primary care. I'm always happy to talk about this topic. It's been something I've been involved with for a long time now, and I always think I always kind of say it's the best thing I've done in my practice to kind of keep me somewhat sane, I think, in terms of my work life. So our objectives tonight will be to understand what advanced access is and what it isn't. See how these principles of supply and demand relate to primary care, just like it does to any other business, whether it's a Jiffy Lube or a Subway. Learn the benefits of implementing advanced access in your office. I discovered the formula that explains supply and demand in primary care. There's like a little bit of math here, but nothing too onerous, I promise. And then discover the practical steps to incorporating advanced access. And then we'll talk about some leadership opportunities at the end. Again, this is an accredited part of the accredited thing. So to do my conflicts, you can just do the next slide there, Melissa. So I'm a co-chair of London Middlesex Primary Care Alliance. I'm a family doctor. I have received some payment for some work with the OHT as the coordinating council rep and digital health working group. Next slide. But no payment for this session itself. This program has received some financial support in the sense of admin support from Melissa and Rachel, but doesn't have any conflicts. I don't have any conflicts in regards to that. So I'll take you back to how I first got introduced to advanced access. So next point, Melissa. So I started practice in 2003, but did locums for a couple of years. And then I took over family practice in DC in 2005. And I was just kind of, just going through the motions of kind of getting my practice going. I had some patients, but I was taking on more. And I was kind of just scheduling kind of just ad hoc and didn't really have any strategy whatsoever. But I'd heard some inklings and some vocabulary around this access, but didn't really know what it was or what to make of it. Next point. So I had an opportunity in 2007 to go to the Institute of Healthcare Improvement Conference. It was in Nashville and was kind of a neat conference to go to, but it was kind of a chance to learn about some more of these quality improvement. Was pretty new-ish at that time, and to learn some more ideas about the model of improvement. But there was an option to go for a day before the conference started, all about advanced access. Next slide or point, I guess. So Dr. Mark Murray from Kaiser Permanente was kind of the I don't know, what do you call him, the guru or the guy that kind of put this whole idea together and really started spreading the word about it. So he was hosting this full day workshop, and it was really incredible for me. It was really neat to hear this guy talking about all these different ways to handle the problem of scheduling, and it really connected with the problems I was having in my office, and this whole room of family doctors mainly having the same kind of problems all across North America. And we were all having the same issues, and this guy had all the answers for how to do it better and different, and it made sense to my head. So I really was quite taken by it and excited to implement some of these ideas in my office when I got back. And beyond that, next point, we got involved with the BC Practice Improvement Program, where we tried to spread the word for advanced access amongst our health authority in our area, doing workshops and group sessions with other docs to try to get them to understand it and implement it in their offices. Next slide. So what is advanced access? So it's kind of hard to describe in some ways. It's not a simple thing. It's not even a thing. It's more like a philosophy, a series of ideas of how to use the principles of supply and demand to help meet the demands of a practice patient population in a patient-centered and timely manner. So that's kind of a lot of things in there, but it is that whole idea that supply and demand does apply to primary care or any practice model, just as it does in any other business. And we're trying to be patient-centered and not timely. So it's not just about us. The benefits may come to us, but it's not just about us. Next point. So if this is all done correctly, the goal is that you are in complete balance with your supply and demand to the point where a patient is able to get an appointment when they want and need it, whether it's today, tomorrow, or 3 months from now. Sounds like it could be, that doesn't make sense, or it doesn't feel like that's possible in your practice, but I assure you, for most PIC practices, it is. It has to just take a little time of rethinking how you think about your practice. Next point. So one of the big things to realize is that even though we feel like we're overwhelmed and we are, inundated with overflow of information and things we have to do, a demand in a practice is actually finite and it is actually predictable. Again, I know it's hard to imagine that, but if we look at, as we get further along, you'll understand where that comes from. Next point. And then the even more amazing part, I think I want to get people to realize, is that most practices are actually meeting the demands of their population right now. They're just doing it late. So what do I mean by that? Well, I mean, if you have a patient call your office and they need a non-urgent appointment, and it's about 2 weeks to get that non-urgent appointment right now, but it's always 2 weeks, like it's 2 weeks if they call today, if they call next week, if they call in July, if they call in September, it's always 2 weeks, then you're actually meeting your demand, right? If you weren't, it would be 2 weeks and 3 weeks and 4 weeks and 5 weeks. But if it's staying at 2 weeks, you're actually meeting the demand. You're just always 2 weeks late. So what would happen if you could change that 2 weeks late part and be 1 day or 0 days? What would happen then? And that's when you get to that point, really the secret sauce of advanced access really comes into play, and you really have a lot of benefits you don't really comprehend until you get to that level. Next slide. So what is it not is something I want to talk about, because there are some, when I was first talking about advanced access all those years ago, there was a lot of different people that were trying to implement it, but we're not quite getting the full concept. They're doing little parts of it, which kind of didn't work very well and kind of gave it a bad reputation, I think. So the carve-out model is not a bad model. It's just some way we do to manage our day and our urgent needs of the practice. Is where you carve out a portion of your schedule for those same day urgent issues, which makes perfect sense, and it does solve some of the major problems we have with access in our practice. So I don't think it's necessarily a bad thing, but it's not as good as advanced access as a whole. And the reason why is because when you carve out those spots for same day urgent problems, you're kind of decreasing the amount of appointments available for the non-urgent stuff. So those people are being pushed back even further. So there is some benefit to solve some problems, but it doesn't solve them all. Next one. There was a weird trend for a while there, and I hope it's not happening anymore, where people were just kind of treating each day as a silo. So there were no appointments made beyond today's date. So it came from, I think there was this kind of terminology, these little kind of catchphrases that were going around, and one was do today's work today. That was kind of one of the things for advanced access. That was the goal, was try to do today's work today. So people started just saying, I'm only going to think about today and only open appointments each day as it comes. So every 9 o'clock in the morning, the phones open up, phone starts ringing, and you had no appointments at 9 o'clock, at 9:10, you're booked. Obviously, that is not very patient-centered, right? Imagine if you had like 1 day off and you're trying to get your haircut, your car oil changed, and a doctor's appointment, and you have to wait till that morning to call to book that appointment. It just doesn't work. And you can't plan ahead, and it's just not very efficient in terms of patient care. And next one. And then there's a walk-in clinic format, which is another type of, I guess, access philosophy, where you don't have any appointments at all. But again, I think we'd agree that that's not very patient-centered. It doesn't allow you to plan for chronic disease management. It doesn't allow you to kind of really work your practice and take care of a patient population. It's a bit harder to do that in a walk-in type setting. So next slide. So another way you can kind of look at the differences in the schedules would be looking at a sample schedule. So in the traditional schedule, when you wake up in the morning, your day is already fully booked. And that gives me palpitations just looking at it, because I don't typically have this kind of schedule where my day is fully booked before you even get up. Because in some ways, with this kind of model, you're already late before you even roll out of bed, because you know the phone calls are going to come. You're going to get phone calls for same day fit-ins, for urgent stuff, what have you. But you haven't planned for that, other than just fitting those extra appointments in on the side, during your lunch break, during your break times, whatever. So that's the start of the day. You're already fully booked. Then next slide. So at the end of the day, now your schedule has kind of changed a bit. You're going to have some no-shows because people booked that appointment 3 weeks ago and they don't need it anymore. They forgot to call you to cancel. You're going to have all those fit-ins that came in. Some are going to be quick, but some are going to be intense and hard to fit in and don't have the room to fit them in. So you're just kind of making time where there is none. And so you're just kind of running ragged a bit. So I really do feel like this kind of philosophy that we're kind of all used to seeing is really a big part of burnout, where you always have that pressure of being late or having no room in your schedule for anything because you're already fully booked before you even roll out of bed. So I think that's a traditional schedule. You may have some different models where you have some extra spots open for same day urgent, but the same issues are still kind of there. Next slide. So in advanced access, we're talking about a different kind of scenario. This is where you have some extra spots already booked into your day or already open in your day. They're not carved out, they're just sort of inherently there because of your getting rid of that wait time and getting to the point where you're on time and able to see people when they need to be seen. So you have space in your schedule when you wake up, and then you know you're not going to be like bored because the phone will ring. You will get appointments. You won't be hurting for work, right? So, but you have space and energy to fit those in. So by the end of the day, next slide, you've had those extra spots filled up with some things that are appropriate to fill up. And oftentimes just short little quick things like a prescription refill, maybe a quick return to work note, like a sore knee, what have you. You may still get, hammered with something that you weren't expecting and that was taking a lot of time and a lot of energy, but then you have a bit more space for it. You have the energy for it. So you can accommodate that a bit easier. So that's kind of what we're trying to get to with that schedule. Now you may not think that's possible, but so how do we get to this point? What's the strategy? So next slide. Well, first, before we get to that, let's talk about the benefits. Why would you even want to do this? And again, I think from my standpoint, the big benefit is for the provider and it is for, that whole burnout issue. But let's talk about the other people involved here, right? So happier patients, I think, is a benefit that we definitely see when you run this model. Patients are able to get in when they need to be seen. They feel comfortable that they can get in when they have a concern. I get thanked pretty regularly about thanks for fitting me in. We're not fitting them in. We're not doing anything special. We're just doing a regular workflow, but they're able to get in and they feel like we've done them a service that way. Next, happier staff. Staff definitely like this philosophy. And I put it like your staff is somewhat selling appointments. Like that's kind of what their job is. And if they come to the work in the morning and they have no appointments to sell, it makes it a tough job. So they have to deal with all that pushback from the patient. So that when they can actually put people in right away, it's really quite easier and much more satisfying. Can help people easier. And that's also even the time of work is quite different, right? I mean, if you have an appointment available, and somebody says, I need an appointment, today for my back, what have you, and they say, okay, we'll see you at 1:30. Great, thanks, see you then. Done. It's a 30-second phone call. Whereas if you don't have an appointment, then you start hearing the whole story, the whole song and dance about why I need to be seen, how severe the problem is. You have to deal with all of that information and becomes a 5-minute phone call. And that's been shown that phone calls become much longer when you don't have appointments available than if you do. And then we go to next point, happier providers. It's for the same reason before, not feeling late before you can get out of bed, but also for other kind of really subtle reasons. I mean, having happier patients and having happier staff all helps you to be happier as well. But also, you have different kind of things that happen. When patients have like a long time to wait for their appointment, they tend to make lists more, right? Because they have time. They know this is a valuable appointment. So let's make a list to make sure I get all my problems dealt with because I don't know when I'll get back here again. So that gets kind of exhausting. When you have the same day appointments available, you tend to have like those spots for the quick UTI, the quick cold, the quick prescription refill, what have you. It tends to break up your day with a mix of those heavier things plus those quick things. So, I mean, overall, it's just a net benefit. And I think once you get to that level, it really is a lot of subtle things happen that you really can't quantify. Next point. And are there system improvements or better care? I don't know. Probably there is some studies about that. I'm not really sure about that myself. Again, that's not my point. It's not about that. It's about how you feel, how you work, how your patients get through. I mean, certainly I think there's value for patients being able to be seen when they can be seen. I'm sure it helps with your access bonus and decreasing emerge use, but I don't have the studies in front of me to tell you about that. But I do think, if no matter how good a doctor you are, if the patient can't get to see you, they can't see how good you are. So I think that's still the first step, is still trying to have access is kind of one of the big things that I think really determines how content and how successful you can be. Next slide. So before we get into the main ideas of how to do this, and that magic math formula to talk about how we can improve how we can implement advanced access, some basic definitions, pretty straightforward stuff. So panel size is the size of your practice population. So that's who you care for, both rostered and unrostered patients. Next. Your supply is basically the number of appointments you have, but it's more than that in some ways. I mean, we're going to focus mainly on appointments, but it's the ability of you and your practice to address the needs of your patient population. So that includes mainly appointments, but also, obviously includes paperwork and forms and reviewing labs, reviewing consult letters, all that kind of stuff. And next. Demand is that amount of work generated by the patient population, right? How many appointments you need to have, how much paperwork are they generating, all that kind of stuff. And then lastly, backlog. These are the number of patients that are waiting for an appointment. And this can be divided into two parts, good backlog and bad backlog. So good backlog is when they're waiting appropriately, and that's kind of what people are supposed to be waiting for, right? They have to for physiological reasons, right? You want to see your diabetic patients every 3 months. You're not going to see them all 4 times in one day. You're not going to see your prenatals all. You have to see them over the course of their pregnancy. You're starting a medication, you need to wait for some time for it to take effect. So those are all appropriate. And you may have some other things that you decide that you're okay with people waiting for, right? Some people may say that I want my, anyone that wants a physical can get it when they can, but other people may say that people can wait for a physical. It's not a big rush for me, and I don't want to worry about that. So that's your good backlog. Bad backlog is people that are waiting when they really shouldn't be or they don't want to be. So that would be pretty much most people that are waiting, to be honest. But again, you have some decisions to make to decide what you feel are okay to wait for, what you feel may not be okay to wait for. But people that have, you don't want all the UTIs and colds and stuff to have to go to a walk-in clinic because they can't get in to see you. Then they get the easy stuff, you get all the hard stuff, right? So that's not ideal. Or if they have something more serious, they need to be seen sooner and they just can't wait. So that's the main definition. So next slide here. So this is the formula here. This is the magic here, right? So it's really just the idea that supply and demand has to balance, and some ways the numbers don't even matter. Just the idea that this formula exists and that it's valid is enough to make you maybe rethink how you think about your practice. Your supply can be determined in lots of different ways, but the simplest way is just how many weeks do you want to work per year and how many patients do you want to see per week. And the demand is your panel size, which is, like I said, your rostered, unrostered patients, times the number of visits per patient per year. Now you can do lots of things to try to calculate that number of visits per patient per year. In general, it's felt to be somewhere between 3 and 4 when you take into account your high needs patients and your young people you never see. And OHIP kind of uses 4 as its number, right? For when you're getting paid for our capitation model, it's about 4 visits per patient per year is what we get paid for. So that's a reasonable number to use, right? So if you look at that, you can plug in any numbers you want and just got to get a sense of where things are at. But I mean, just for examples, we just threw in some simple numbers, right? If your panel size was say 1,200 with 4 visits per patient per year, doing math I kind of did earlier, so I don't have to think too hard about it now, it's 4,800. So if you were to work, let's say 48.
Vineet, can you hear us?
Yeah.
You froze. Oh, you froze.
I froze. Okay.
Yeah.
Sorry, I saw other people
Back
froze
now.
on me. When did I freeze?
You
Talk
kept
about math.
going, so I'm not sure.
Where did I freeze at? The formula or not?
Yeah, we heard part of the formula.
Okay.
Oh,
Okay. Fair enough.
there you go.
Thank you,
Good
Julie.
going, Julie.
Thank you, Julie. Someone's paying attention. Thank you. Sorry, I'm gonna just pop out for a second here. Check my internet. Looking okay. Okay, fair enough. Okay, sorry about that. Yeah, no, just talking about the balancing part of the equation. If you just took the general numbers of 1,200 patients, 4 visits per patient per year, that comes out to 4,800 patients or 4,800 visits per year. So if you did 48 weeks per year, times 100 patients per week, that's around 4,800 as well. So that's in balance. So again, it's more just the idea that this formula exists and that you can kind of determine whether it's even possible to be in balance. And that's kind of the first step of implementation. We'll go to the next slide. So how do you get there? And the first question is it possible? Are you in the ballpark? Are you close? If you're seeing 20 patients a year and you have 20 patients per week and you have 2,000 patients, you're probably not going to be in balance without making some significant changes. But if you're somewhere close, I mean, again, you don't have to do the exact calculation if you don't want to, but if you're somewhere close, I think then that you think, okay, I can get there if I put my mind to it and I put in these ideas into place. So that was step one. The step two is the harder one, eliminating your backlog. This is the one where people kind of sometimes will get a little bit, challenging because it is a bit of extra work, right? It's talking about seeing extra patients. We're all working hard, and seeing more people seems like it's an impossible task. But overall, we're not talking about doing this forever. It's kind of a short-term thing to get you down for something that I think is truly valuable and helpful. And it could be just seeing, a couple extra people a day. It could be seeing an extra hour of patients over the week somewhere, however you want to do it. But it does kind of take that little bit of extra work. But I would argue that we all do this already. When you go away for a holiday, you come back and you end up seeing more people when you come back, just to kind of get back to your baseline. So the same kind of way you do that, you just kind of keep on going. Don't settle for your baseline, try to take it even further so you get that backlog even more reduced. Next. And then we'd increase your supply, and then we'll talk about some ways to do that. And then next, decreasing and controlled demand. So I kind of write this as 1, 2, 3, 4, but really 2, 3, and 4 all happen at the same time. So we'll kind of keeping that all in mind as we try to implement these ideas. Next. So increasing supply, there's a few ways we can do that. You can see more patients, which again, we talked about already. So not everyone's first choice, but it's an option if you feel like you're really out of balance, you need to get more patients per week. Next. Eliminating bad backlog. Again, by getting rid of that bad backlog, it does increase your supply because you tend to not have as many no-shows. You tend to have some general, again, secret sauce thing that just sort of happens. If you kind of get that anxiety down, people don't just book appointments just in case they need them later on. Next. You can get help. So that could be, getting a locum to help for a period of time, using some allied health professionals to help take some of the workload off if you can, with nurses or RPNs to help with some of the work. Next. Improve office efficiency. This could include any number of things to try to help your flow better. So you can maybe free up a bit of time. So whether that's using our EMR better, improving your office workflows, so you're not looking around for supplies or results when the patient's in the room. And maybe it's using secure messaging or phone calls more efficiently so that you can maybe, do 5 messages to go over results for the patient with 5 patients rather than, 1 patient in 10 minutes in the same amount of timeline. So, and next. And then decreasing appointment types. This is one which I always think is kind of a neat way of looking at your practice. It's kind of like the whole analogy of a grocery store line versus a bank line. So if in a grocery store you have all the different checkout counters, you got to pick one, and once you're in that line, you're kind of stuck. And then the bank line, you have that one line with all the tellers available to everybody. So if you have a lot of different lines for different types of appointments, you have patients being forced to be in a line when there could be a shorter line somewhere else. So if you can open up your schedule by having fewer appointment types, it opens up your schedule to more people and makes the line move faster. Next. And then we'll talk about decreasing and controlling your demand. Again, I'm harping on eliminating bad backlog, but again, it does help to reduce your demand. I think when people just feel able to get in, they just don't feel that need to book those appointments that they don't need to. Next. Directing your follow-ups. This is, again, going back to that idea that demand is finite and predictable. So, if you see a patient on a Monday with some, whatever reason you see them, whether it's a pneumonia or you're starting them on a blood pressure pill or antidepressant or what have you, and you say, oh, you just kind of throw it away, I'll follow up in 2 weeks or a month or whatever you want to say. But that's going to be 2 weeks is going to be on a Monday as well. And Mondays tend to be busier days. So why don't you say come back on a Tuesday or a Wednesday when it's not as busy? So you can kind of just guide those people to where it's a little bit more manageable. In general, the philosophy is book early and book late. Book early in the day because when the phones open up, you're not going to get a whole lot of same day urgents for first thing in the morning, and then book later in the week because it tends to be less busy as well because you've kind of caught up in the weekend and all that kind of stuff. Next. Decrease the visit frequency. That's, if you have some routine habits of just having people come in every 2 months or every 1 month to get refills or to follow up on something, but they're stable, maybe you can push that to 3 months or even 4 months, depending on your comfort level on what you want to do. Next. And maximizing visits. Common in the faux world where you're trying to do as much as you can in one visit rather than having to come back 3 times for one problem per visit. So you can get it all done at once and not having to come in as often. And next. And then responding to temporary increases in demand. This is just about, this is not a one-time thing. You always have to kind of look at your schedule and kind of make some adjustments depending on the day, week, time of the year. So I'll have some flexibility in my schedule where I might want to add a few more at lunchtime because I'm full, or because I had a meeting and I had to have fewer hours one day so to make up for somewhere else. So you're always kind of making some adjustments, maybe for flu season, what have you. And also, again, we do this all the time with the holidays and stuff. We'll tend to add more spots open when we get back from holidays. One of the great ideas I like about holiday planning is if you are booking a holiday off, say taking a week off, you book off your Monday to Friday off for that week, but then also book, Monday, Tuesday, Wednesday off for the next week. And then when you go on your holiday, you open up those 3 days that you had held off as well, so that when people call during the week that you're away, they have 2 or 3 days to fill up, to have appointments available for them for while you're away. So not push back even further down, like a month down the road, what have you. So those are all those kind of things to kind of look at your, eliminating backlog, increasing supply, decreasing demand. So that's really the whole gist of it. I mean, I went through it pretty quickly in terms of advanced access. Again, I spent a whole day on my session before when I first did it, but it's more just to give you some ideas and to think about it. Next point. But overall, I think I just want you to realize that, supply and demand does apply to primary care just as it does in any other business. Next. Your demand is finite and it is somewhat predictable, so you can use that to your advantage. And next. Again, the thing I would like to reassure people even more is that most offices are keeping up with their demand, right? The formula does actually balance out pretty well. They're just always 2 weeks late. So if we can get that down to 0 to 1 day, then you've made a huge difference, and it's doable. I think that's just the most, because again, I think you can look at that formula and just realize that you should be able to, if you have 1,200, 1,400 patients, what have you, you should be able to keep up with the demand. Next. Again, eliminating backlog is the most important, most challenging barrier, but that's where the investment is really, it's worth it, it's doable, and it's short term, just trying to get you to that point where you could really reap the benefits of advanced access. Next. Again, my sales pitch again is still the best thing that's helped me in my practice. And finally, again, if you want a resource for this, next point there, Melissa, I wrote an ebook just to kind of write all this stuff down because it was in my head, and it's on our website, corefamilyhealth.com. If you click on physicians, the first point is the advanced access ebook. You can just click on it, and it's just the same stuff we talked about here, a bit more detail, and you can kind of look at it at your leisure. Yeah, so I think that's the end of my talk. I know there's lots of different scenarios that people have for their practices. Maybe there's some different questions that have come up if they want to ask. We got a couple minutes to think before we wind down. Yeah, if anybody has any questions, please feel free to fire away. I see in the comments there. Yep.
I'm going to probably go look at your ebook.
Yeah.
In a past life with the old Partnering for Quality team that I used to work with, we had some QI coaches that would actually go into practices and help with advanced access. But coming from a physician's point of view, I'm going to go and download your ebook. It's probably a lot simpler than what was put out as a toolkit from, I think at the time was Health Quality Ontario. It just seemed very complicated. That it was hard.
That's kind of what that was kind of my take on it. They had a lot of, doing a lot of calculations and third next available and doing the math kind of, again, I don't think you need to be that complicated. Just start doing it and you'll get there. See a couple of questions. Everyone in our group uses advanced access. got a couple of colleagues on the talk here today. I think we all do like parts of it. I think we use some aspects of it. I don't think everyone does it as militantly as I do. It doesn't have to be your whole group, though. To be honest, it can be just you. I think it's just more as long as you can convey it to your staff and what you're trying to do. But yeah, it doesn't have to be everybody in your group. It can be just one doc in the office that wants to do it. Planning for the excessive number of forms. Yeah. It's that's kind of one of the things, right? I mean, I've heard lots of people talk about their concerns with going with advanced access. This doesn't really affect the forms, but again, it is part of that demand is the work, right? So, I mean, when you have not a full, when you come to work and your day is not full, you have some room to do those kind of things. And one of my favorite questions with people, like when they're in the fee-for-service world, is like, what if I don't make enough money because I don't book enough people if I do this model? And that to me just says, well, that means the only reason you're busy is because you're inefficient, which is really bad, right? So, I mean, I think if you are, if you do have a capacity in your day, then you can, do the extra forms you need to. You can call people in, but the forms are there anyway, so you might as well do it with more time on your hands than to have no time on your hands. And I do use online appointment booking, and that's another, where I kind of go more all in for advanced access. I kind of keep my online appointment bookings. I just keep it open. Like, book whatever you want. I don't really care. And that kind of helps my staff because they don't have as many phone calls and they can kind of get people, they'll be booked in without much influence from them. But if you have just a very small number of, well, if you have, again, multiple lines in your online appointment bookings, that can throw things off, right? If you only have like, one for PAP here, one for physical there, one for child thing here, that one appointment that could take, someone that wants that appointment could have to wait like multiple weeks to get an open one, where there could be other spots that are available. I don't see any more questions, and we're kind of running late, and I want to give some time for the not late, but we're running on time, but I don't want to run late, so that we have time to talk about the leadership opportunities. And yeah, please do look at the ebook. It really has most of the questions I could think of are there, including an FAQ kind of section in that. And it will kind of fill in any blanks of stuff that you may have missed if I had froze or talked too fast here this evening.
Thanks, Vinny. Great. We'll move on to our last part of the agenda. Thank you everyone for coming today. I'm going to share kind of our promotional poster for the LMPCA. I think it's a nice overview of kind of things we've done and kind of how more people can participate in some of what's going on. I'm not sure, is this big enough to see, or should I make it bigger? Okay. Sorry, I can't see anyone. It's big enough. Oh.
I gave you a thumbs up, Melissa. I have bad eyes, so I can kind of see it. If you want to make it a little bit bigger, maybe, but.
Yeah. Right. I'd like, and Vinny and Scott, feel free to jump in if you have anything else to add, but what LMPCA is really is a collective group of primary care practitioners working in London and Middlesex. We also have a number of representatives on our executive council from the primary care organizations, like Scott himself, he's the CHC, but we've done a lot of different things in the past number of years. Some of them are outlined here. Really, a lot of it was focusing on some of the COVID supports and pandemic supports, and there's a PPE kind of hub that we're able to get PPE out to offices, primary care offices, as well as help in some of the vaccination clinics, and just kind of giving up more resources for primary care. And then we've done a number of these town halls on different topics. We have kind of a regular newsletter that goes out to kind of make everyone aware of all the going on in primary care. And we really try to make this local to London and Middlesex, so you can get the information that you need for any kind of local activities. So what we really are asked today is kind of to try to get more people involved in LMPCA and some of the other activities that are going on that we often get asked for volunteers or for people to join working groups or different project teams. So a lot of that information does go out in our newsletters, but we just want to kind of highlight some of them and make sure that people are taking the time to read it, or and just let this group know too that you can always contact us. There's quite a large number of opportunities to get involved. There's a couple listed here as you can. We'll be having more people join our executive council in the near future. We'll have there's a lot of working groups and different projects going on from the Middlesex London OHT. There's other opportunities. I'm going to share one with you in a couple of minutes here. It's just about there's such a wide variety of it, and that they don't all take a huge time commitment. There's kind of varying degrees of how you can get involved, and we're always willing to kind of chat with anyone in primary care, and if they want to get involved, we'll find you the correct fit. Most of them are actually reimbursed or for physician time and NP time.
Yeah, I'll just chime in there, Melissa. Like, yeah, I think that's kind of what we're asking for here. Like, we have lots of people are reaching out to primary care more than ever to get our input, which is great. We just are running out of hours in the day to do that kind of stuff, and it's really sometimes it's not a huge amount of time commitment. It's just getting that primary care practical input, which everybody I'm sure that works in primary care would be fantastic at. So we don't like having to be the same people all the time, and we don't want like saying no either. So we'd love to kind of, if you do see some opportunities come up that you're interested in, to please volunteer for it. And again, most of these now we've kind of advocated to make sure they get paid for. So we do make sure that when we do make the ask, that we kind of say this is expected to be this much time commitment, and that this would be the remuneration rate or what have you, or there is or there isn't. But typically now there is. So that's kind of a good thing. Yeah, and I think so. If you see emails, just please consider them. And if you have areas that you're interested in really working in, maybe you could even proactively reach out to us. And then if something comes up in that vein, we can kind of tap you on the shoulder.
Thanks, Vinny. We did have one opportunity, just kind of a little bit topical to what our first topic tonight for the mental health. I think, Rachel, you said that Tanvin's on the line. Maybe you can speak to that.
Tanvin is on the line. There she is.
Hello, I do have a slide. Should I share my screen really quick?
Sure, if you want, you can share it.
Perfect. I won't take too much of your time because I know it's been a long night, but my name is Tanvin Janeja. I am the Knowledge Mobilization Specialist for the London Middlesex Mental Health and Addiction Strategic Direction Office. Our short form is SDO. And we are working on a project related to a coordinated service response for crystal methamphetamine, and it builds on the work of the community drug and alcohol strategy. Our project is now entering the co-design phase, and we are looking for input from service providers, business providers, and people with lived experience, which is why I'm here to talk to all you service providers. This includes healthcare workers, frontline workers, social workers, primary care providers, any sort of health service providers, to join either an advisory committee related to validating the ideal pathway for a person who uses methamphetamine, or participate in co-design sessions for educational materials and training materials that we will be creating for the target groups that I mentioned, business providers, service providers, and people who use substances and their caregivers. I am going to link the website that has a lot more information. It has our reports posted, but if you are interested, please let Summer Thorpe know. Her email is on the slide. And I think it's also in the slide deck that I think Melissa will send out after. So you will all have access to it. The time commitment is 10 hours for the advisory committee over 1 hour meetings for about 8 months. And then two 1 hour long meetings for the co-design sessions for input on education materials. This comes from the fact that we know we aren't the experts and that you folks deal with this day on end. So you folks are the expert that we should talk to when it comes to pathways and trainings for this population. Yeah, please let me know or Summer know if you have any questions.
Thank you for that. Yeah, I don't see any questions in the chat here, so nowhere. I know, Rachel, if you wanted to share anything very, very quickly, we have a minute or so left.
Yeah, I'm just going to put it right in the chat. If for those of you who might be on LinkedIn or Twitter, I know it's been circulating. Trudy DeVries, however you say her name, it's going to be in the chat. She's the lead for the navigation planning. And what the Middlesex London Ontario Health Team is looking for is another co-design session, so similar but different session, looking for clinicians who could really bring their voice to the table in terms of their barriers, their challenges, but opportunities for helping patients, caregivers find the services that they need. And we've heard that that was a big issue. So Trudy, would love to hear your thoughts. I'm just going to put it in the chat with her email. And hopefully, if you're interested, again, feel free to reach out to Trudy. Compensated time as well. So we really need your voices at the table. You guys are the ones that do it day in and day out, as Tanvin said.
Thanks, Rachel. All right, I think that concludes our session for tonight. I don't know, Nate, Scott, any final words or?
No, thanks everyone for their attention and for attending tonight. I learned lots from the first talk, and hope you guys got something out of the advanced access side of things. But thanks again for your time, and please look out for any emails from us about other opportunities, and look to see if one of these ones are of interest to you as well. Thanks so much, everybody.
Have a great day.
Thank you, everybody.